Good afternoon, everyone. Good morning, good evening to all of you. We are happy to welcome you at another Interprofessional.global cafe. And today we will discuss and hear from a researcher on interprofessional education and a very interesting topic on the meta-analysis of RCTs in IPE and its relationship into education, professional practice, and also in terms of healthcare outcomes. And just to give you an overview of how this works, we normally would have 20 to 30 minutes of discussion from our speaker, Matthew Kerry, who is a researcher at the Institute of Public Health at the Zurich University of Applied Sciences. And then after his discussion, we will have time to have an open forum where you can ask questions and our speaker will be able to address your questions. I think we are all set. I think, Matthew, the microphone is yours.
Thank you so much, Michael. Thank you, everyone, for joining. We had a little Markov chain model game going on with the link, so I hope we all converged here. Yeah, thanks, Michael, for the invitation, and thank you, Allison, for helping troubleshoot. Thanks, IP Global, for hosting. I'll be hopefully pretty short here. I'd like to sort of have everyone give an open exchange to, stimulate the conversation here, because this is a very new finding. So we're still formulating sort of the substantive impact of what we've done. So the title today is Interprofessional Education Effects on Professional Practice and Healthcare Outcomes. Let's see if our animation works today. All right. MA of IPE RCTs is how I lovingly call this. I try to keep everything simple without using too many acronyms. I'm just getting over a little bout of COVID. It's still a thing. So I'm imagining all of you guys in the Doha dry air. So I hope that sticks with me as we go through the presentation. Speaking of COVID, once upon a time, 3 years ago, gather around everyone. It's really important that you share your nose hairs with the webcam so that we can have a free information exchange. 3 years ago, in the heart of COVID, I was working on a meta-analysis for IPE. And this was like a really, I thought, attractively ambitious idea. And then I had a meeting with Andreas because I realized I needed more help for how much, for the scope of the thing. So I reached out to Andreas Ziegrist, the chief editor of JIC, and he said, Matt, I'm extremely busy. It's fascinating what you've done, and I'm really impressed that you've done it alone. And let me just pause on inviting me, and I'll get back to you in a year. And I said, oh, well, that was like the nicest way, the new editor could blow me off, and that's fine. So then a year went by, and now it's like 2022. And sure enough, Andreas got back to me and said, hey, Matt, we're actually going to get together with the other reviewers or the co-authors from a 2013 paper on Cochrane that was a systematic review of IPE studies. So this is a 10-year update from 2013 to 2023. And we are obviously in need of more co-authors. And we would love for you to join us because the systematic review could just be, a vehicle for the meta-analysis if we in fact find a high enough sample. So I jumped at the idea, and so we took it from there. That was sort of the pretext for getting involved with this current study. So with that, I just have to say, I have to acknowledge Andreas, Laura, Joanna, and Merrick Swadenstein for bringing me on board, because I couldn't have done any of this without them. So here's a little bit what we're going to talk about. I think I have 20 minutes. I'm going to try to keep it concise and precise. The previous systematic review to now will sort of serve as the backdrop. Shouldn't try to admit people as I'm talking. I'm going to go into the search results of the updated review, and more importantly, the DV synthesis. So how did we categorize our outcomes? Because this is something we've gotten some, a few constructive critiques, would be the very nice way of saying, some pushback on how we've done the analyses. And then I'll go straight into the main effect results, the subgroup results, and then leave it up to discussion and questions. But I do have a plethora of extra slides. If your interest is piqued, we can keep going into those subgroup results, because I'll just say there's way more that were done sort of ad hoc, casually on my own that didn't make it into the paper. So there's about 5 that went in the paper, and anywhere between 10 and 15 that were too like low end to really be suitable for publication. So, but I'm happy to dive in those if you're, if you have the interest. Let's see if I can keep your attention. We can stop sharing nose hairs now. Okay, so this was the original review. You may or may not be familiar with it in 2013. There's 3 things I want to say about this, please. First, we owe a great deal to Scott Reeves still, and probably forever. There were mini and varietal studies, so they had a pretty good batch of studies of 15. I mean, not like, not an embarrassing number, not a shameful, like under 10 number, but not a huge number, like over 50 either. So there were many diverse studies, 8 RCTs, 5 CBAs, and 2 ITSs, which were interrupted time series. This was kind of the design du jour, like 10 years ago. I think this was kind of like today's clustered randomized trial, right? Or today's step wedge design. Like, it was just sort of the flavor of the month way back then. But maybe, I don't want to offend anyone. And the third thing I want to say is that one of the conclusions from the study was that a meta-analysis was not possible due to the heterogeneity. So I want you to keep that in mind as I come back, and we'll circle back also to the DV synthesis. Okay, so Andreas convinced me to drop my sort of broad scoped IPE analysis, which included a lot of different study designs, and join up with them. And we reviewed a lot of abstracts. So abstracts for exclusion, full text for inclusion. But essentially, we had to come to a decision point if we were going to admit the control before after designs like we did in 2013. And I think they expanded this because there just wasn't sufficient sample size. So they had to expand beyond RCTs. There was only 8 in 2013, but we found 16 additional ones. So we decided to drop control before afters or the interrupted time series. Okay. These are the folks involved in the primary studies. And we wanted to compare IPE with an active control or no, to a control or to a sort of an inactive intervention. You could think of this, if you speak clinical trials, this would be like your efficacious study, right? Like your early phase, IPE versus control. And this would be like your effectiveness study, like IPE versus monodiscipline intervention, or a generic like team training intervention, but not necessarily interprofessional focused. So either or. Here's the flow chart you are all familiar with. So here's our reasons for full text exclusion. We've basically added 16 new randomized control trials to the original 8. 2 did not make it in the analysis. And I went back to the paper to remember exactly why, because it was a lot. And one of them was a design issue. It was a non-inferiority design. So they tested 2 groups of IPE. And there was just one was in one setting, like a classroom, and one was in the clinical setting, but there was the exact same intervention. And so it wasn't really, I would say, a fair test to understand the efficacy of IPE versus a control, let's say. They were too homogeneous in this way. And the second issue was one of the studies reported incident rate ratios, and this was a temporal-based statistic, and we just couldn't, or at least I haven't found a credible way of converting that to a generic point estimate vis-a-vis like Borenstein's comprehensive meta-analysis, which is what I was using. So yeah, these are the settings. Here's just some descriptives of those final 24 randomized control trials. So a variety of settings. I was pretty surprised with the split in the classroom and simulation settings. They lasted anywhere from a half day was the minimum to like 2 full days, or 16 hours as a maximum. Right. So our primary outcome, as you see, it's all the long text, but I try to keep things simple. These are patient outcomes, okay? Objectively measure or self-reported. Could be something as simple as, collaborative behavior between the providers, transparency of information, or simple satisfaction. Anything like that would qualify as a patient outcome. And the secondary outcome was probies, or provider behaviors, right? So if you're more familiar with Kirkpatrick's model that extended to Barr et al.'s, 6-level model, I mean, this roughly aligns to level 4B. So benefits to patients. We analyzed everything at the individual level, nothing at the unit or hospital level. And then behavioral change. So this is the providers. We all okay so far?
Yes.
Excellent. Thank you, Jan. All right. So let's get to the good stuff. I meant to say, and I'm sorry, this was my failure to disclose. If possible, it would be great if we all adhere to an honors policy of not necessarily screenshotting or sharing this stuff. I mean, if you guys want to take notes and then share your notes when anything else you present going forward, that's fine. But a lot of this stuff is still under revise, resubmit, and review. So I would appreciate if you guys didn't necessarily screenshot with sources and all this good stuff. It's almost like no good deed goes unpunished. So, but if you guys want to take notes, like on the number of studies coming out from meta-analysis and the effect sizes, you guys are welcome to do that. But try not to. I don't want it to be the identifiable source. All right. Here we go. So results are reported, very intuitively. Okay, it's according to Cohen's d rubric, or even a correlation coefficient. If you really want to simplify it, basically 0 to 1. It's a standardized mean difference of 0.4, 0.4 to 0.7, or greater than 0.7. You guys know the rubric. Here's a nice table I like that just shows the reference with the method of how the outcomes were reported. So there was 3: objective, other reported, or self-reported. I hope that's fairly heuristical and clear. And this is the specific outcome, so patient outcome or PRO-B. And again, these are like this is the definition or the detail account of the data we extracted. So Clay Williams contributed an other report of professional behavior, and this is the familiar Mayo High Performance T-Work scale. Nothing fancy there. We could go down to Strasser and see that they reported a patient outcome, and it was motor functional gains greater than 23%. And that's how they defined it in the paper. We didn't do anything. We didn't transform anything. We just took their data points and synthesized it. Fair? I'm glad Merrick forced me to make this table. Okay. So the main effect for overall, so all the studies sort of ignoring whether they were categorized as patient outcomes or PROBs, provider behaviors, was 0.47. And if you're not familiar with a forest plot for meta-analysis, essentially your squares here are your your effect sizes, and then your bars are your 95% confidence intervals, and 0 here would be like a null effect, okay? And everything on the positive side would be favoring IPE intervention. Everything on the negative side would actually be disfavoring IPE intervention. So, for example, the first study, in fact, Brown from 99, they found an effect that was non-significant because it overlaps, but it disfavored the IPE intervention, or it favored the control in this case. And it's just, it looks a little more neat because we organize it as a cumulative meta-analysis, so it admitted each new study to give you an overall estimate of the effect size. And as you see, about 60% of the way through, the effect becomes significant. I'm not sure if you can see my mouse, but starting from Barcello, 2010, the 95% confidence interval gets off of the null point estimate. It does not cross 0. And then down here at the bottom, right, so that's your overall estimate. So basically we just have, according to Cohen's rubric, we have a medium or moderate effect size. I think we're doing okay on time. So let's break down those main outcomes. Here it is again as probies, the primary outcome, and patient outcomes. Probies is the secondary outcome. Patient outcomes is the primary. But basically, it's a small to moderate effect for patient outcomes and a similarly moderate effect for pro behaviors. These are the contributing studies. We okay? Moderate effect sizes for each outcome. We'll come back to it if there's questions. I want to get to the subgroup analyses because this is what I think is really important. This kind of goes to the approach or reasoning for conducting the meta-analysis in the first place. So there's 5 variables we coded for here. I'm not going to reread them all for you. Right, so fidelity is participation level, right? Or like whether it's mandatory or freiwillig or voluntary. Training content is whether it's established or not, right? And then sometimes we found for IP focus, it was a singular module versus like a tack-on module to other communication training or patient safety training or something like that. And then intensity was a one-off versus multi-module or multi-day activity. And follow-up time was sort of a nominal or gratuitous subgroup we created because I'm super popular at parties and I enjoy running continuous moderators in meta-regressions. So I wanted to have a continuous moderator. So that we looked at, let's get to it. Now, to give you a little tutorial on how we read this again, I'll make this super simple for anyone unfamiliar with it. Just bear with me if you are. What we essentially want to look for here for each subgroup is the difference between the subgroups here, okay? So here we have high fidelity or high participation, low fidelity, low participation. And we want to know if there's a significant difference between the two groups. And then, in addition, we could take a look at the actual significance within the groups. Is that fair? So these are the 2 things we're going to read. And after that, we're going to go through them. So for example, for this subgroup, this says that there is a significant difference between high participation or low participation. Excuse me. And sure enough, when we go as expected, sort of theoretically or postulate-wise, high participation leads to a more significant effect, or the effect is significant in this group, and it's sort of borderline significant in this group. So, I mean, one practical, and this is just, again, postulation, speculation, conjecture. I mean, one possible inference from this could be that there's a benefit, let's say, to making your IPE programs or deliveries mandatory, perhaps. Okay. Excuse me. Established versus local training. So this is like team steps, very common, well-developed training programs versus locally developed, which could also be, again, inferred as something like bespoke or custom or etc. So here there's no difference between those groups, and it is significant in both groups. Is that fair? So you could infer that as there is meta-analytic evidence supporting the efficacy of bespoke IP deliveries or customized deliveries suited for the student population or the target population. Okay. Excuse me. And this is based on our third subgroup was standalone versus bundled. Okay. And there's no difference between the groups, but it is significant in both groups. And again, obviously, when it's a standalone intervention, the effect is a little bit higher in that group. The fourth subgroup is intensity, so one-off training or not, or more. It's non-significant between the two groups, but it's significant within both groups. And again, as we'd expect, sort of directionally, high intensity, a very high significant effect, slightly lower for a low intensity, but they're still significant. Make sense? I can't tell you how thrilled I was when you get done with the months of churning through abstracts in full text and seeing some sort of intuitively substantive value, like in the direction of these findings. Yeah, it might be a simple satisfaction, but it's certainly satisfying. And then the time continuous, again, this was the difference between the exposure to the intervention and then the point at when they assess them post. So these are days, I believe. Yes. So these are like days. So this might be indicative of, let's say, I don't know, a dormancy effect or a latency effect or a saturation effect, right? Like maybe some provider attitudes change immediately, whereas I'm sure some patient outcomes probably don't change till distally, right? So it's a difference of proximal versus distal assessment. And the effect was actually significant. This was kind of surprising, but nice to see. But this is also a bit difficult to read into because this is, again, combining the two outcomes. So it could just be like provider behaviors are all assessed down here and patient outcomes are assessed up here, right? That's probably a fair idea for another figure. All right, those are the subgroups, the beta effects and subgroups I have. I think we're okay on time, but I do want to wrap up and give you guys a chance to view more. So to conclude, there is meta-analytic evidence for RCT supporting IPE's causality, for probies and PAD outcomes. I also want to make a note that the quality of the evidence has improved. So not for naught, but 10 years ago, the quality of evidence was quite poor, according to grade, and now it's moderate. So we're getting there. Also, heterogeneity can be expected, especially in this heterogeneous content domain of IPE, okay? It's a broad theoretical content domain, if only evidenced by the samples, right? The diverse disciplines. So I'm not surprised that there's heterogeneity, okay? And remember, meta-analysis was founded on the idea of estimating a point estimate from randomized controlled trials, because the idea was that even if you had sample variability, to the extent that there are confounds, they would be distributed by token of the randomized design, right? So in this case, it's just a matter of saying like, okay, do we want a single point estimate or do we want to see how much variability there is? And then can we account for that variability or can we explore it? Does the point estimate move in the direction we would expect based on, for example, high intensity versus low intensity training, right? This is not, to me, this is not a barrier to the meta-analysis, even if there is, let's say, heterogeneous outcomes. So I'll get off the preaching unit right now. I'll just say explore variability, don't disavow it. Yeah, I hope that the results are encouraging. My take-home recommendation would be keep it simple. I'm not speaking for my co-authors, right? So this is not necessarily in the paper, but to you guys as the IP Global audience, I would recommend keeping it simple. Randomize participants to two versions of an online question. Like, don't get caught up in the nuances of the randomized trial. Yeah, it's not biochemistry that, you need to account for oxygen molecules in the outer ring. It's just, you don't need to account for a blinding, right, of your assessors. You don't need to account for blinding of the assignments, or even I mean, it's good to account for those things, but you don't have to. Like, don't impose barriers on yourself. Don't make it more difficult than it needs to be up front. Just focus on a simple variation that you can easily implement via randomization, like a link randomized 2 ways. I wonder if there's like a mirror group audience waiting in another room right now. Probably not. Okay, so yeah, consider randomizing units instead of individuals. So maybe it's tough randomizing 500 folks, at an individual level, but maybe you can implement IP at a certain number of cantons or counties or clinics, and have another active control, like just patient safety training or teamwork training, and just assign them based on the unit level. Maybe that's much easier to run. Yeah. So these are just a couple ideas of how to sort of, promote more RCTs in IP research. I don't want to take up any more of your time because I value you guys' insights much more than mine. So I want to thank Michael and thank IP Global. There are some additional post hoc tests but I'll leave it up to maybe Michael as the moderator to see, should we explore questions from folks, or do you want me to go through the post-group analyses if you guys are interested?
Well, Matt, if you'd like to share some more slides or some more information, then you can do that. And then we have people asking some questions, and then we can proceed with the open discussion. If you have some more slides to share.
That's super.
Yeah.
Absolutely. All right. So it's almost 3 o'clock. Hopefully we don't have a huge drop off. Let's do 5 minutes for like 10 post-group things. And remember, these is stuff not in the paper. Yeah, but I think it's interesting. I'm a variability guy, right? One thing we looked at was classroom versus clinic. So as you see, like there was only 2 studies in the clinic, or I'm sorry, in the classroom. So that's why it didn't go in the paper, because it's sort of a nonsensical group. I mean, the heuristic is to have 3 or more studies, like at the primary study level, for a credible subgroup analysis. But, you know, that's just a number someone chose. The numbers don't know where they came from, right? It's up to us. But yeah, there's a significance here in the hospital clinic. Here's one's levels of care, primary, secondary, tertiary. So I just coded all these studies, right? So there's not a difference between the groups, but here I suppose is interesting. Again, it just happens to be the largest group, and the secondary care is where we had a significant effect. And it could just be because there's 5 or less studies. I can't say, but I hope this makes sense. Publication yet, this was a thing that I was sort of interested in terms of, are we getting better at implementing IPE over time, sort of as a period effect, right? Like, are we still building paper chain rings, or are we doing something more clinically relevant? There was a positive coefficient, but it was not significant, but that's all right. Validated versus unvalidated measures. So these were like the self-reports and other reports, like the rating scale. So sometimes folks said, oh, we had a locally developed patient satisfaction questionnaire. And that's like, you know, great. But you forgot to report the reliability. Is there any psychometric study of this scale, et cetera, et cetera. So there was not a difference between the 2 groups, but satisfyingly enough to me, like, yeah, the valid measures, which yes, happens to be the largest group. Again, I think this sort of coincides with the fact that we took RCTs, right? I think it's a stronger, I suppose, design if you come from that camp. So there's more studies with valid measures, and that's where we find the significant effect. Original versus new studies. So this was like the original 8 RCTs from 2013 versus now. This was sort of a spin. This is what I came up with when the regression didn't come out over publication year, right? So I was pleased to see that there was a significant effect, excuse me, in the new studies. Power analysis versus no power. So now we're geeking out, right? But I mean, for the strength of the RCT designs, I was curious. Hey, you know, like a third of them don't do a power analysis, but 2/3 do. That's pretty good sample distribution, you know. And so this actually came out to be a significant difference. But when I first saw this result, I was kind of, I was a little bit despondent, I guess, as a statistician, because I saw that for the no power analysis group, they had a highly significant effect. And for those who conducted a power analysis, it was significant, but, you know, closer to that 0.05 cutoff. And then I thought about it a bit more. I didn't ruminate too much. I thought about it, and I thought, oh yeah, well, the people who are doing a power analysis technically are only recruiting the number of people they need to achieve the effect. So in a way, this is actually a bit encouraging. In other words, you could look, I mean, again, inference, cognitive dissonance, you could label it whatever you want, but you could infer this as being the people who conduct a power analysis are not collecting more waste. It's less, let's say they're not having more people in the study than they necessarily need, or they're not overpowering their study. Pure conjecture. Objective other versus self-reported outcomes. So 14, 8, 6. There's significant for the, I mean, this is kind of expected, like, right? Lower standard error of measurement. That's why physicians and health professionals love quote unquote objective outcomes. So like H1AC levels, blood fat lipid levels, weight, right? So physical measurements versus other report and self-report. I kind of like that this is sort of in the direction of how I would think about the validity of the measures. And then I combined other and self-report here to just be subjective measures versus objective measures. So here it became significant, but it's borderline. But there's not really too much to read in there. This is all just sensational extra slides that I'm showing you guys. I thought you might find it interesting. I mean, this was the breakdown according to Kirkpatrick's model. So again, that's why we had provider behaviors. I think, these studies, they also reported provider behavior. So that's what we report. But there was a couple that reported attitudes and knowledge, and they're not significant, but it's only 2 and 3 studies. So, the fact that it's 0.13, I'm sure if those both went up to 5, it would probably become significant. Am I still under 5 minutes? I am. I'm gonna leave it, I think, at that. Not a lot of evidence for publication bias, a little bit for provider behaviors here on the right, but fairly marginal. Not ignorable, but not substantive. Okay. So with that, I would open it up to questions, thoughts, comments, and thank you for your attention, and thank you, IP Global.
Thank you so much, Matt. That was not easy to do. I mean, to kind of synthesize all these information, quantitative information in 20 to 30 minutes. But great work, like what Tony said, I concur. And we have some questions, Matt. Are you happy to answer them?
Please.
Okay. So we have one question from Cynthia Andrews. Cynthia, would you like to ask? Do you want to speak, or would you want me to read it for you?
I don't mind speaking. Thanks so much.
Okay,
Matthew.
great.
Can you all hear me okay?
Yes,
Yeah.
okay, great.
So thanks very much, Matthew. That was very, very interesting. I just had a logistics question about, could you just describe a bit more to us what you mean by high intensity versus low intensity interventions?
Sure. So the high intensity was a single training. Low intensity, I think that was 4 hours or under, like a half day training, like a morning or an afternoon. And then high intensity was anything above that. And that purely came down to the frequency distribution. So like roughly half the studies had a training that was 4 hours or under, and roughly half the studies had trainings that were 6 hours plus.
Thank you so much. That really helps.
Okay.
Okay, thank you, Cynthia. We also have another question from Amy Blue. Hi, Amy.
Hello.
Hi, Amy.
Again, great and impressive work, Matthew. I just wanted to clarify for myself and maybe for others, were most of these studies with healthcare professionals or students, or what was sort of the breakdown between, practitioners, professionals versus students in training?
That's a great question. Yeah, the majority was healthcare professionals. I was actually looking in the paper yesterday. Excuse me. We had actually excluded students, and I don't believe we did. I think it just came out that like 85% of the sample was healthcare professionals. But let me check real quick, if you bear with me. Yeah, see, I looked here and I was surprised I didn't see this broken down further, but I recall that we had so many healthcare professionals. I think the criteria, though, was that they had to be post-licensure, if I'm not mistaken.
Okay, I'm just saying, and I'm not going to make the correct attribution to another article that was published, I want to say this year in Journal of Interprofessional Care, was not the kind of work that you've done, but something similar, and looking at a variety of studies on the effect of IPE. And again, one of their takeaways was a lot of this work has been done with professionals, seeing positive effects, not as much done with students, and we could chat about the variety of reasons for that. So I'm seeing that your work is providing, again, really helpful evidence about the effect of IPE interventions on one patients and professionals. Mm-hmm.
That's a really great comment. Yeah, thank you, Amy. That's exactly right. And I remember you were on another meta-analysis, I believe. The one I was working on, as Andreas came to me, actually focused on pre-licensure students, and mainly because of the volume of evidence, but also because I thought if there is funding need from sort of essential academic publication, let's say, or an ancillary one, then I thought it should probably come, or probably rightfully devoted to pre-licensure training. But that's just because that's where my heart was when I did the master's on pre-licensure IP students. So, but yeah, I hope that there is more. Frankly, I'm surprised that there's so much RCTs in post-licensure and clinician samples.
Right.
I would think from an administrative perspective, it might even be easier to do it at the pre-licensure level, but we'll see.
Yeah, and I think one of the things to think about at the pre-licensure level, if you're going to look at patient outcomes, is that gets really murky with students at the pre-licensure level. But
I'm so glad you said that. That tickles me. I'm so glad you said that, because it really is. It's a question of the longevity of the effects, or sort of the duration of the effects, versus the juxtaposition of the trainees and the target population. So, I mean, to me, it's like you could probably find a lot of negative reactions to IPE if you only have a voluntary sample pre-licensure, or if you only administer it in, I don't know, I'm speaking in broad strokes here, or, for example, or if you only administer it in older clinicians, perhaps, right? But on the other side, if you look at something distally like patient outcomes, you're right, I mean, in principle, separated or distanced from the IP training environment at pre-licensure level. But you also have things like community placements, where I think IP is destined and belongs to. And in this way, you don't have to sort of wait for the traditional continuity of care. There was a great article back in like 2015 or 17 in academic medicine that talked about, how many compounds and how many intervening variables we need to account for through the training track. And that's why it's difficult to estimate. That's one way to, that it is analytically super difficult, but it could also be super simplified by a design adjustment, right? If we use optimal design theory, we could just put the students next to patients, and they may or may not like it, or it may or may, I'm sure there's all kinds of administrative and licensure barriers to that, maybe even liability barriers to that. But I would bet perhaps that the patients may actually respond to student trainees, depending on the context, more so than veteran clinicians.
Absolutely. And I just had one more thought, and then I'll let others chime in, is if, and maybe in your work you've seen this, if the interventions done with providers, if anybody has tracked, was this a first time interprofessional education intervention for that particular individual, or had they had previous ones? Because in my own mind, I'm thinking at least those of us working with students at the pre-licensure level, we're priming the pump, so maybe people are more receptive, or whatever additional training they get in their own environment, then is more impactful, as opposed to if they never had any exposure.
Absolutely. And I think that's really important. I'm making a note of that, because that might even be something we potentially could code for.
Right.
And something that's kind of a worthwhile research idea in itself. Someone did a Veterans Affairs administrative data analysis of participant reactions to team training, and they, because it was wonderfully booked administrative data across 20, 30 years, they were able to actually isolate a cohort or a period effect. And I said, oh, well, that's the effect you probably want to see in terms of, are we getting better at delivering the training, taking out all the other within individual effects. I mean, it's just, that was more of like a top-down approach of doing it. But I agree with you, simply accounting, a lot of folks, IP is sort of matured. So the question is, have they been previously exposed? I think that's a very worthwhile inquiry.
Well, thank you again. Terrific work. And this is going to make a significant, I mean, we all know this is making a significant contribution.
Oh, I hope so.
Thank you, Amy. Just to keep the ball rolling, I have a question, Matthew.
Yes.
Regarding, you mentioned a while ago that you said that it would be better if the IPE program is mandatory rather than optional. And can you explain a little bit about that based on the results that you got?
Yeah, absolutely. That's a wonderful question. So again, this goes a little bit back to the Kirkpatrick model here. If we look up at it, the idea is, you know, if you make the training voluntary, and then you want to measure something like reaction or attitudes. Let's say you come in and do, I don't know, a controlled before after design. If you make it voluntary, it's likely that most people that are signing up already hold IP in high regard. It may be that the students we assessed in the 90s, when we found pretty robust effects for, hey, is your mother or father a doctor? And then this somehow had like a pretty reliable but marginally negative effect on IPE perceptions. You know, it could be 20 years, 30 years later now that this doesn't apply, this phenomenon, that there's been sort of a normalization of IPE training, God willing, I hope. But it's just to say that if you make it mandatory, the idea is, you know, when you want to look for change, you want to have people in the middle on the latent variable or on the lower end of the latent variable to assess that change. Otherwise, you just run into the ceiling effects. And ideally, if you mandate it and you randomize it, then hopefully you have people from all from across the latent distribution, you know, high, medium, and low levels. But then you randomize them to whether they're exposed to the intervention or not. And then you can measure that change. So that's what I mean by there's that if you make it voluntary, there's obviously the very well-known self-selection bias that comes into play. Like people who want to be there will be there, and they'll already think that IP is the greatest because it changes colors and spins and it's holistic and it, you know, but others may not show up. And so you're probably not going to detect a lot of change. So I just say it's a statistical precautionary.
Okay. That's good. So Matthew, just a follow-up question. Is this study already published? I mean, the updated version, has this been published already?
It has not. It's gone under review and now we're
Okay.
resubmitting it.
Okay, great. And where will it be published? Can you say that? Can you say
I
where?
cannot. I'm sorry.
Okay. All right. Then when it's done, we will share that to all of you. Okay. So I would like to ask the group, we still have, you know, Matthew, you have 40 plus participants coming in to
That's
this
fantastic.
webinar. Yes, that's fantastic. Do we have anyone from the group who'd like to ask questions or make some comments, reflections on the topic on this meta-analysis?
Matthew, this is really important work. Thank you for doing this and keeping this, you know, this probably is a process that needs to be refreshed frequently. So I think this is wonderful. And we look forward to sharing it. I just wanted to add a few things about, we do have another Global Cafe on June 18th. And then we have another one on July 2nd. So make sure you put those on your calendars,
Will do.
folks. But I want to step away and let someone else ask questions. Thank you.
Thanks, Tony.
Thank you, Tony. Hi, Kevin. Yes, Kevin, you can speak and ask your question. Yeah.
Hi, and thanks, Matt, for your presentation. It's really fascinating, and I'm glad you've done this study. I have more a comment rather than a question.
Please.
So this is something that I recently learned, and I was involved in some guideline developments, which included evidence review and meta-analysis. And I learned recently that you can do qualitative analysis of randomized controlled trials.
Love that.
And that, I'm sorry?
I love that.
Yeah. And that might give you additional data, that supports the quantitative, aspects of the meta-analysis. And I wonder if this was something that you might want to consider doing.
I think that's probably the most provocative comment I've had thus far. It's really good. Yeah, I tell my quant students every year that, you know, it's a false divide, right, between the qual and quant, and we can qualify the rigor of the quantitative studies, and we can quantify the qualitative content. So the idea of combining the design with the qualitative analysis makes infinite sense to me. This is sort of, I wonder how we would do that in terms of like whether or not we need qualitative data at the primary source level, or would it be qualitative data generated at the secondary level? Do you know what I mean?
Yep. And I'm no expert in this area, so this was something that I recently learned. But I do know of someone who might know the answers.
Yep.
And I would be happy to link you guys up if
please
you're
do. I was just going to ask for a source. That would be really wonderful. Yeah, I think the last time I chatted about something sort of so meta juxtaposed, I was chatting with someone about like years ago about the idea of, you know, we could impose a meta analytic design, or I'm sorry, a meta analysis on any sort of design we want. Like, for example, if we wanted to know, we could randomize meta-analytic approaches to the analysis, right? Like, should we be using reliability corrections versus not? Like, how does that then we would have some causal statements about the efficacy of detecting subgroup differences, things like this. So I like the idea of using qualitative analysis, sort of, excuse me, transforming it or generating it into quantifiable data. I mean, the whole name of the game here is getting some sort of ordinal level variable so that we can get a generic effect estimate. So again, whether it comes from us generating qualitative aspects of the study, like, did they get ethics approval? Did, you know, like simple checkboxes, yes or no, like however we want to qualify it at the secondary level. Or if we want to say, oh, we're only including RCTs where they used feedback from the participants or from the facilitators. And then that would be like qualitative data at the primary level. And both are attractively ambitious. So yeah, please link me with your colleague.
Yeah.
Thank you.
So I put my email in the chat.
Very cool.
And I will be happy to continue this conversation with you.
Me too. Thank you.
Great. Thank you, Kevin. Thank you so much. I think, Matthew, you also receive a lot of positive comments about how enlightening the work is, and the great discussions, and people are seeing importance in the work that you're doing currently.
That's good.
Yes.
That's good.
Good. We still have some time. And there's a question but this is more like an administrative question. If this recording will be shared to the participants. Yeah, normally we do share the recording to the participants and in our website as well. So anyone else would like to ask Matthew some questions, or maybe comments or reflections regarding the topic? Kevin, are you raising your hand? Is this a new hand, or is this a hand that was not put down?
No, it was a previous hand. Sorry.
Okay, all right. Yeah, I would. Oh, yeah, we still have a little bit of time. Any other questions for Matt? Or maybe Matt, you can, I mean, for sure, some people are still reflecting on your presentation, and I think it would be nice if you could share your email to the group, maybe in the group chats, so that if in case like Kevin would like to connect and collaborate with you in future research, then you know they could contact you.
Absolutely.
Okay. So Matthew has just shared his email address. It's kerr@zhave.ch. Can, of course, message him in case. So I think there are no more questions, but of course they can ask you asynchronously. And any final words, Matthew, about your paper or anything that you'd like us to update us with? Any upcoming projects?
I'm just really enthused. Well, I hope to see you guys at the next Altogether Better Health.
Yep.
I'm going to continue with the work, and maybe one day I'll get back to the original meta-analysis I was working on. The trouble doing it individually is that you need to document the whole process so that it's credible. So unfortunately, the one-man goal alone doesn't really work at the end. So I'm going to I'm encouraged by the number of RCTs. I hope you guys are encouraged to make some simple implementations of RCTs, and if don't be afraid of the heterogeneity, right? Like it's all good. I mean, there was a great article in Journal of Patient Reported Outcomes a few months ago that queried a bunch of doctors how they use their objective instruments. And so it's obviously from advocates of patient reported outcomes trying to get their instrument on the same playing field as other clinometrics. And basically what they got back was all the doctors said there is no really objective instrument. They're all sample dependent, right? So even something like weight, if you use a new weight cutting drug, if you use it in eating disorder or old adult or young children samples, you're not going to get much change. So it doesn't make that much sense in this way. And this was kind of my attitude towards the idea of people advising against combining heterogeneous outcomes. I mean, this might be a bit much for this audience for like the meta-analytic level, but I just say try to use validated measures, surely, or objective measures, but also keep it simple, and don't be afraid to use multiple instruments. But also keep in mind of the response burden. I do have to mention that if you have shorter measures that are also validated, equally valid, then don't necessarily think that just collecting more questions is better. It's usually the other way around.
Great. Thank you so much. Thank you so much, Matthew. And we are just so grateful to have you and to be sharing with us all this information, encouraging us that IPE is indeed something worth doing in practice and in education. So we have a lot of positive comments for you and for the positive interest they have on your presentation. And we'd just like to announce that the next IPE Global Cafe will be on June 18. You can click this link for the information. There are people messaging us about the timing. That's a very good feedback for all of us. And the time is there in the website. So if you have any questions regarding the logistics, let us know. And if there are issues in checking in to the Zoom link, let us also know. It's really good feedback for us. Thank you very much.
One bit of clarification around, we'll try to always use UTC. So especially with daylight savings time for people, it comes at different times of the year. This time of year can be a little some of the time zone changes. So you might when you schedule, might want to use UTC to verify it on your schedule.
Yes, thank you, Tony. And thank you very much, Matthew, for this presentation.
Thanks for having me.
Thank you.
Thank you guys for listening. Hope to see you out there.
Yes.